Okay, our talk is going on to a bit more information about endobronchial ultrasound and diagnosing tuberculosis. Been doing some work with Alice at Homerton here, along with Dr. Bomick, Professor Bothamley, and one of our house officers. So, EBUS TBNA is now the standard of care for investigation of intrathoracic lymphadenopathy, and it's been very well validated in malignancy and sarcoidosis, as Gillian touched upon. But the literature available for intrathoracic tuberculous lymphadenitis is pretty limited, actually. I'm just going to go through some of the work that's out there.
This study was published on CHEST in 2004 and is about TBNA diagnosis in intrathoracic tuberculosis lymphadenitis. Blind TBNA were obtained in 84 patients with mediastinal lymph node adenopathy, suspicious for TB. TB was confirmed in 76 patients, and TBNA was diagnostic in 73 patients. Adequate specimens were obtained in 85% of patients, and the histology was compatible with TB in 48 patients. Cytologies in 9, and microbiological culture was positive in 17. This paper is a China's study published in 2013 and is about the role of TBNA EBUS in diagnosis of intrathoracic TB in China. The study was performed using EBUS TBNA for lymph nodal lesion and parenchymal lesion suspected for TB. In this case, parenchymal changes were included. In 59 patients, TBs was confirmed in 31, by EBUS TBNA alone in 25, and by bronchoscopy in 2, and we both in 10.
Thanks. So if TBNA's got a reasonable sensitivity, it would stand to reason that using endobronchial ultrasound would help your diagnostic yield. And the next paper is one that you might have read. It's sort of the biggest paper in this area, and it's done at 4 centres, Papworth, Guy's, Mary's, and at UCL. And they looked at 156 patients who had an EBUS TBNA, whose final diagnosis turned out to be tuberculosis. All the patients were identified retrospectively, and that was either by them going on to have a mediastinopathy or what they described as an unequivocal response to treatment. And they reported that EBUS was diagnostic of tuberculosis in 94% of their patients, and they had consistent pathological findings in 135 of these, and I'll go on to what they mean by that in a moment. But as Gillian pointed out, the culture rate's still quite low. It's only 47%. This is the pathological grading system that they use for their FNA samples, and it's based on some work that was published in a cytopathology journal some years ago, where they used FNA of cervical lymph nodes. So they grade pathology grade 1 as representing granulomas with necrosis, pathology grade 2 with just granulomatous change, no evidence of necrosis, 3 just represents necrosis, 4 is non-specific, and that would include normal lymph node and reactive lymphadenopathy, and 5 would represent an inadequate sample. They do stipulate that grades 1 to 3 considered consistent with TB, but only in the context of appropriate clinical features and investigations, which they state interferon gamma release assay or MON2 test. So, just to go back in time slightly, the Homerton has done some work into this before in the past, and which Dr. Bomick was involved in, where we used EUS FNA to identify mediastinal lymph nodes where there was a high clinical suspicion of sarcoidosis and tuberculosis. This led to a relationship with the Cytologic Institute in Hanover, which has a slightly different approach to cytopathology, and it turned out actually that one of the pathologists at the Royal London Hospital who processed our samples went to the Hanover Institute to learn some slightly different cytological techniques for processing our EBUS samples. They quoted for this paper a sensitivity for tuberculosis of 86%, and sarcoidosis, they quite impressively quoted at 100%. So, The EBUS service at Homerton has existed since April 2010, and we've received over time referrals from Barking, Haverington, Redbridge NHS Trust, which is Queen's and King George, and Berks Health, which is Newham, Whipps Cross, St Bart's, with Royal London and the London Chest Hospital. Some of these centres now set up their own EBUS service, so we don't receive referrals from anyone, but I think perhaps importantly we do receive a large number of referrals from Newham Hospital. It wasn't intended to be a joke, but... one of my predecessors looked at the initial work that had been done at Homerton and looking at diagnostic yield, so whether there was identifiable lymph node in FNA samples or tumour indeed. From the first 126 cases, they showed that there were 14 cases of tuberculosis within that, 11 of which were culture positive, and 3 diagnosed on consistent pathology, so those grades 1, 2, or 3, and the clinical picture. So that's, although a small number, quite a bit higher than the culture positivity rate quoted at UCL. What does that mean for us now? So the aim of this piece of work was to review all the cases of EBUS TBNA that had been performed at Homerton to assess what the diagnostic yield was, how often we were getting lymph node, tumour, and the sensitivity for all cases, but I won't focus too much on that. Specifically for tuberculosis, what's our percentage of smear or culture positivity here, and what percentage of our patients have consistent pathological findings with TB, so using that same pathology grading system. We also wanted to look at which lymph node sites were sampled and aiming to see whether or not we could establish a relationship between the site of the lymph node and whether that tended to culture positivity. So, a rather long, arduous process, but using a bronchoscopy reporting software, we're able to identify all EBUSs performed since its inception here at Homerton. We then used our EPR system, clinic letters, patient notes where possible to obtain relevant clinical information and most importantly the final diagnosis. That involved quite a lot of ringing around and speaking to the referring hospitals, and then match that clinical information with our local cytology and histology reports, the microbiology reports which are processed here, and additional information gained from the Cytology Institute in Hanover. All our non-malignant results were checked through our London TB register and checked with the referring hospital to try and catch all cases of TB. So, since starting, we've performed 363 EBUS procedures here at Homerton, and there's only been one complication, which would support the theory that's quite a safe, non-invasive procedure. And we're able to obtain lymph node material or definite tumour in 340 of this, which is 94%. Where lymph node material has not been able to be identified, there's usually a reason given for that. Either there was crush artifact in acquiring the sample, too much necrosis, which I'll come on to again in a minute, or difficulty in aspirating the lymph node in question. I won't dwell too much on the numbers, but as you can see, the majority of which is done for either the diagnosis or staging of malignancy. And I'm sure this will provoke some questions at the end. We've identified 64 cases of sarcoidosis and confirmed via EBUS 57 cases of tuberculosis. So, then working backwards, establishing all cases of tuberculosis that have had an EBUS procedure here at Homerton. We can then look at how many of those EBUS was used in the diagnosis and also the pathology grade which was found, adding into that whether or not the culture was positive. So of 63 patients that were eventually diagnosed with TB who had an EBUS here, there were 25 who had necrotic granulomas, of which 18 were culture positive. However, there were 23 patients who had just granulomatous change on their histology or cytology samples, but interestingly, 15 of those were culture positive. Grade 3 pathology would come under the initial remit of a non-diagnostic sample, but if that sample then goes on to be culture positive, I think that should be included. Stage 4 again is reactive lymph nodes or normal lymph node sampled, but again, 4 of those 9 patients went on to be culture positive. And the non-diagnostic sample, unsurprisingly, was not culture positive. So having my screen's gone. Touch it again. Okay. So I haven't included on the slides, I don't want to ruin my nice infographic, but there's no statistical difference between pathology grades 1 and 2 as to whether or not you're more likely to have a positive culture, depending on your histology grade. So some other key findings. So of 63 patients that eventually were diagnosed with TB, 57 EBUS was diagnostic, either by suitable pathology grade and clinical information or by a positive culture. We only had 4 patients who had smear positive samples, and 2 of those, as was touched upon earlier, was when there was a paradoxical response to treatment and enlarging mediastinal lymph nodes, and that they were shown that there was no culture there, but there were acid-fast bacilli seen. We identified 5 cases of drug-resistant TB on culture. So, looking at the cases that we're unable to identify, and looking at the hospital that referred them, and where the eventual site of disease was registered on the London TB register, you can see that where you might expect us to have picked up some of these cases, most of these cases would not have made it into the previous work, as they were specific that isolated mediastinal tuberculous lymphadenitis should be the only condition included. So just a quick reminder of your lymph node stations in case you'd forgotten. It shows that the vast majority of node sites sampled were station 7 and 4R. And in previous literature, it was thought that 4R would be the right paratracheal would be the most common site for tuberculous lymphadenitis. But this agrees with the data from the thorax paper in 2011 that the majority of samples were from station 7. There's more samples there than there were patient, and that's because some patients had 2 nodes sampled. So, I'm sure this will be the question that's provoked from what I've spoken about how do we know that we're not diagnosing sarcoidosis where it's culture-negative TB. And I think that's a valid point. And because we operate external referrals, we don't have a standardized length of follow-up. But we should be able to obtain that information eventually, so perhaps we may find some additional details. Also, when patients are referred, it's a fairly informal referral process. Sometimes just an email to Dr. Bomick. So the workup before they get to EBUS would perhaps not be as standardized as you'd like. And I think what's probably slightly disappointing is that although we tend to record quite well at the time of sampling, the node sample often doesn't make it through to the pathology report, so it's very difficult to show a relationship between the node sampled and whether or not that became positive or not. So just to acknowledge people that were helpful in obtaining the clinical information. And any questions?
I just wanted to know what's your length of culture time, because I've often found working at Homerton that they just the culture was like 4 weeks throughout the samples at 6 weeks.
So it's different. Prof might be able to answer this in slightly more detail, but there's a variety. Obviously, if it becomes positive, then that stops there. But we do go up to 84 days in some cases. And I think in the thorax 2011 paper that was based at UCL, I think that they didn't have a standardized culture time, and one of the sites was using an extended 84-day culture, and I think that turned up 3 additional results. Anna?
Could you comment on how much of the sample ends up going to histology?
It's obviously variable on the amount that is sampled, but typically we'd have a formalin pot for histology, and then 2 just universal 60 ml containers, one which would usually be split equally between a cytology sample and a microbiology sample. Additionally, if Dr. Bomick wants to contact his friend in Hanover, he'll make up slides to send to Germany as well. So it's a mixture, but usually the same amount for cytology and microbiology.
Does that vary with your index? To some extent. I don't think it's particularly scientific. I think we get a the background to sending samples to Hanover is that, fortunately, I think we've been led by gastroenterologists in much of the stuff that we do, which is a sad state of affairs. But they developed all these techniques which we are now beginning to take up. And I was taught how to do EUS by Frederick Rowan, who's a gastroenterologist here, and they have historically sent their samples to Germany for processing. And Philippopoulides, who's a cytologist in Germany, has worked on the analysis of mediastinal lymph nodes for many years and has published a lot of the initial papers on this subject. So we started off sending samples there, but and it's important to remember that with pathology, there is a bit of a learning curve, and it takes some time for pathologists and cytologists to learn how to analyze and report these samples. So that has to be taken into account. And as things have progressed at our local lab is the Royal London, and their reporting has now got better, so I tend not to send so many samples to Germany anymore. Started off by sending everything there, and that's our sample.
Yep.
Patients with TB, were they referred to as with strong suspicion of TB, or were they just...
Some are, some aren't. So it really, so if you have a, I don't know, I suppose, a 45-year-old sort of new arrival to the country who's you know, got a cough but smokes heavily, I think that, you know, you have to, and you find mediastinal lymphadenopathy, I think, you know, you have to investigate that regardless. So some with a higher index of suspicion of TB, and certainly the ones that we do in-house, it's for confirmation of culture, ideally, a mixture.
A lot of the external referrals were just mediastinal lymphadenopathy query cause, so it wasn't necessarily with a high suspicion.
The actual diagnostic team fired on this one. Absolutely.
I mean, most of the cases diagnosed in the region, a lot on washing, so you only get a small cohort of individuals who haven't been diagnosed by the usual methods. More difficult to diagnose cases.
No?
There's actually more that Dr. spoken about. I just wondered what the learning curve was in terms of diagnostic positivity. Diagnostic, and lots of places are now setting up very robust.
For culture, it hasn't really changed. I mean, the first slide showed, which showed our first 18 months of data.
It says 96 for the first, so it's the same.
Over the last 4 years, it's gone down slightly from 96 to 96.
Since October 2013.
That's typical. The reason for that is that when you start doing these things, you should always select your cases. If you're planning to start up an EBA service, start off with big, juicy lymph nodes that are easy to aspirate. Now, as time has gone on, I'm even getting patients who, for example, somebody else has had a go at another hospital with EBUS, fail to get the sample and then sent to me. So we're certainly doing lots of higher lymph nodes. Left-sided lymph nodes are particularly difficult to get at. You know, technically, it's a difficult position. We get those samples, and they're now they're certainly more difficult than the cases I accepted in the first year. So as the degree of difficulty has gone up, I suppose our yield has gone down slightly, and that's to be expected. Thank you.